Hello students, good evening, namaste and hope you all are doing good. So we all have discussed a lot about mechanical ventilation in the previous lecture series. We discussed from the physiology and then we also discussed about the various modes of ventilation. We also discussed about the heart-lung interactions and then we also discussed about the very common conditions like ARDS as well as COPD. So today we'll be discussing about the acidosis, a very common conditions we see in an ICU setting. So as well as this is one thing that since most of these patients are always on a in an ICU, so you are regularly checking their ABG levels. So how do we actually monitor and manage these patients based on those things that we'll be learning today in the part of acidosis part, as well as what we'll be learning is we'll be learning in brief about the BiPAP, the ventilator in an acidosis. So there are two kinds of acidosis. We can have a respiratory acidosis and we can have a metabolic acidosis. And again, both of these can be compensated or non-compensated. So whenever there is a respiratory acidosis, there will be a compensation by the kidney. While if there is a metabolic acidosis, there will be a compensation by the lungs. So that is, and just to know that when we will be just talking about in brief, so we have a normal ABG when we'll be talking about it. So we have a normal ABG finding. Let's say we have a pH of 7.35 to 45 is considered normal. PCO2 of 35 to 45 is normal. PO2 of 75 to 100 is normal, while the bicarbonate levels are 22 to 26. So when we are basically talking of any ABG findings, so how do we see? The first thing we look as pH, then we look at is a PCO2 and the bicarbonate. So we have mentioned, so let's just give some numbers to it. So let's say you come across a pH of let's say 7.2. You all know it's low because you all have read. And then you come across that the PCO2 level is 60 and PO2 level is 60, and then so you know this pH is low and this PCO2 levels is high. So basically what is CO2? CO2 is a carbon dioxide. So carbon dioxide whenever is mixed with water, it gives rise to a carbonic acid. Since it's an acid, so it rises pH. So basically carbon dioxide is basically a Lewis acid. It's a Lewis acid. That is why if there is a rise in CO2 levels, there is a decrease in pH or there is increase in the acidity. Similarly, bicarbonate ions, bicarbonate is a basic ion. So when there is the bicarb levels go down, it leads to acidosis. So here, what kind of picture we can get? Either you can have a piece HCO3 levels of 24 or you can have let's say of 32. So what does this mean? So we have a low pH. So that means this patient is definitely suffering from acidosis. Now we see, okay, the CO2 levels are high, so that is definitely because of something problem in the lung. So that is because of respiratory acidosis. Now comes the portion, of course, we can see that the oxygen levels are also low. Now when we see, the important thing is the bicarb. So the bicarb, so here you can see either it's, what is this? Either it could be normal or it could be increased. Increased means, so if it is normal, then that means no compensation has occurred. And if it is increased, then basically what is happening is compensation. Now, what is the thing? If there is now the kidneys actually takes time to kick in for compensation. So if there is a rise in CO2 levels, actually the bicarbonate levels start rising approximately 2 to 3 days. So if you get this kind of a picture where there is no compensation, what you are looking at is the acute respiratory acidosis. So it's an acute condition. Now, what is the importance of respiratory acidosis? Respiratory acidosis is a very common finding. Why? In every lung disease. So let's consider why it's important. So let's say there's a problem in a ventilation. So if there's a problem in a ventilation, neither the oxygen can go in nor the CO2 can go out. So what will happen? This CO2 will start building up in the blood and the oxygen levels will start dropping. So what you will get is, you will see rise in CO2 levels, and what you will get is a you'll see is a drop in the oxygen levels. So this is a very common finding. Similarly, the same thing, let's say there is a problem at the gas exchange. Again, if there is no problem in the gas exchange, ventilation is normal, what you will see? You will see rise in the CO2 levels and you will see a drop in the oxygen levels. Now the role comes here is when there is a role, so when we are talking of acute respiratory acidosis, means the patient is not having any chronic disease. So let's say a patient of ARDS, so a very new setting condition or acute lung injury patient, in the when you intubate, so at that time when you do an ABG, you might actually see a condition of acute respiratory acidosis without compensation. But when we talk of condition where for a long time body is actually compensating for this increase in CO2, is basically the COPD condition. So in a chronic this condition, so when there is compensation, what are we looking at is a chronic condition. What are we looking at is a chronic condition. So in this portion, sorry. So in this portion, what we saw is basically, so we talked about the COPD. In the COPD, we actually talked, so if there is compensation is already occurring by the kidneys, you do not try to overcompensate. So if you do the overcompensation, like let's say you have this kind of a picture of 7.3 of 60 of 60 and 30, and if you try to make it to let's say 40, then what will happen, this will actually become 24, and this may become, of course, become 7.4, and this will of course become let's say 80. But then when you wean off these patients or ventilator, what will happen, because the COPD is a chronic condition, this will again go back to 60, but this will take time. So what will happen, this pH will actually drop to 7.0, and that's a very bad condition. The patient will again land up in ICU. So of course what you do is you correct CO2 levels to the level where you are actually getting some compensation. You do not, so basically in condition of COPD, what you do is, or whenever there is a chronic respiratory acidosis where there is compensation, you only correct a level of on basis of bicarb. You do not overcorrect. Okay, you do not overcorrect these patients. Now let's talk about something of metabolic. So that we talked about respiratory acidosis. So now let's talk about the condition of metabolic acidosis. So again the same condition I'll just mention. So we got a pH of 7.2. I'll mention the this thing later, and let's say we have a oxygen of 70, which is a very good oxygen, and we are having a bicarb of 16. Okay, now when we are having a bicarb of 16, you can either have, let's say, this, or you can have it to be this. Okay, so what you are seeing basically, so here pH is low, so either this could be normal or this could be low, and then you have this, and then this bicarbonate is low. So basically this is correlating with bicarbonate. So we are dealing with something known as a metabolic acidosis. Now either you can have a normal this carbon dioxide level, or you can have a low carbon dioxide. If you have a normal, then there is no compensation, but if it's a normal, so if it's a low, let's say it's 20, then this means there is compensation. Now let me just tell you, we in the respiratory acidosis, I told you that compensation by the kidneys is usually late to kick in. But when we are talking of lungs are actually very fast. So usually it's very rare that you get this kind of a condition. Actually it's a rare thing. you usually get whenever you see a patient with a metabolic acidosis, they are always coming with certain amount of compensation. Now you will be talking, okay, there are two kinds of acidosis. I'll not go in detail about acidosis. So just in brief, so there are two kinds of acidosis, a high anion gap and a normal anion gap acidosis. So high anion gap and a normal anion gap is very simple. Normal anion gap basically means the things which we are measurable in terms of a pH. So basically anything which is disturbing your normal pH by increasing the carbon dioxide or decreasing the bicarbonates will lead to a normal anion gap acidosis. So you can say, let's say a patient is having diarrhea, okay, or a patient is having a lot of vomiting. So those kind of condition actually give rise to a condition of acidosis, which will be basically which will be the metabolic, which will be a normal anion gap, because that will be hampering the bicarbonate levels. Now a increase in anion gap levels is whenever there is increasing something which is not measurable. So that could be either, let's say, ketoacidosis. So diabetic ketoacidosis is a high anion gap acidosis. Similarly, we have a lactic acidosis. So lactic acid is a different thing that is not we are measuring. So that's a high anion gap acidosis. Or we can have a ethylene glycol poisoning that will present as a high anion gap. Or a patient has a salicylate poisoning, so he took a lot of aspirin, so that again will be a high anion gap metabolic acidosis. So that I will not go to what are the difference, but basically what we are interested right now is in the ventilator setting. So the patient is of this condition, you are getting this. So just remember, how does this actually happened? How does this compensation happened? This compensation will be happening with the help of respiratory rate and tidal volume. You remember the previous classes we talked that respiratory rate and tidal volume determines the CO2 levels. So this particular compensation is happening because of this. So these patients will be having a high respiratory rate and will be having a tidal volume high. So basically not even high, because the respiratory rate so much, so they'll be the tidal volume will be something around 400. So you can say basically they'll be having a shallow rapid breathing. So even when you see these patients, they are metabolic acid. Let's say a patient of diabetic ketoacidosis, so they are kind of altered sensorium, and you see those shallow rapid breathing. So you should a young patient with shallow rapid breathing with altered sensorium, you should immediately think that the patient might be actually having a DKA. So this is how we basically go about it. So let's then now here comes a role of a very important thing that is known as a minute ventilation. So again, let's say we have the same thing, 7.2, we have 20, 70 and 16. Okay. So, and the patient was earlier breathing at a rate, when the patient immediately came to ER, the patient was breathing, let's say, of 30 breaths per minute. This was his respiratory rate. And the patient was having a tidal volume, let's say, of 400 ml. I'm again saying it's a kind of a shallow breathing. So what is a minute ventilation? The minute ventilation will be 40 into 30, 400 into 30, that will be like 12 liter per minute. So this is why this is happening, because this is happening due to compensation. So now you find, okay, you need to intubate this patient saturation is not very well, you need to intubate, and you just kept the same settings, like you just kept the same setting. You had I'll just write it in a different color. So you kept the setting, let's say, okay, we'll keep it at AC, we'll keep it at 12 at 500. So you remember, this is a respiratory rate and this is a tidal volume. So now how much minute ventilation are you giving to this patient? You are giving 6 liter per minute. So now just remember, when you are doing this, just think, what will happen to this compensation? Just think about it. What will happen to this compensation? What will happen to this pH? I'll tell you what will happen. This particular thing, so what you are having of 7.2, 20, 70 and 16, If you do that new setting, what will happen? This will change to somewhere around immediately to 7. This will start going up to, let's say, 30. This will remain, let's say, 72, and this again will remain 16. So basically what problem has occurred? This has become worse. So you have actually worsened the condition. So before you give these patients bicarb, so of course in these patients you need to push in fluids and lot of bicarbs. But before you before you intubate, you need to you need to understand the first initial setting which you do during in these patients during metabolic acidosis. Always think about the minute ventilation. Do not try to reduce the compensation by the lungs, else this particular thing which will happen will cause cardiac arrest immediately. This sudden drop in pH will lead to cardiac arrest. So this is very dangerous. It is catastrophic for the patient. You need to keep this in mind. Okay, this is very important. So all in all, what I want to say is, in a patient of metabolic acidosis, so apart from that, the fluids and bicarbs which you will be giving, when you initially intubate this patient, stimulate the same respiration before the patient, when the patient came to ER, when the patient before intubation. Stimulate the same respiration patient was having before intubation. So this is very important, because if you don't do, you'll actually be landing these patients into a very difficult situations. So now, so we have discussed about the various vent settings of based on acidosis. We talked about the respiratory acidosis. We talked about the compensations in those patients and how do we do it. We also talked about the metabolic acidosis. And again, metabolic acidosis is also a common manifestation during a septic shock. And in COVID-19 as well, these patients are actually going into septic shock and they are also having metabolic acidosis. So you need to be very careful in these conditions. So here during the metabolic acidosis, there is a role of minute ventilation. Of course, whenever you see these patients on a pure metabolic acidosis, there is a very important role of bicarbonate, and when those bicarbonate levels starts improving on ABG, then you actually reduce your do those settings back to what you were doing. But when you initially intubate, you need to be very careful. You need to just give those same air the patient was taking before intubation. Now in the next part, we'll be just discussing in brief about the BiPAP. So basically BiPAP is a non-invasive ventilation method which is given with the help of a mask. The best thing which I would say is a CPAP, not a CPAP, it's not same, but just like a CPAP. So just like you have seen those grandmothers or in those obstructive sleep apnea patients who are carrying that small machine with them and they are taking that with the help of a mask over their nose. That is basically a CPAP mask, and we also have a very similar machine of a BiPAP. So what does BiPAP means? So BiPAP is we are having bi is 2 level. Bi means bi-level. So we can do 3 settings in it. So one is known as a IPAP, the inspiratory positive airway pressure, the EPAP, expiratory positive airway pressure, and FiO2. Again, FiO2 is the same as a fractional oxygen, because majority of these BiPAPs are in an ICU settings where you have the oxygen cylinders or the oxygen supplies where you can monitor the amount of oxygen to be given to the patients. So now we'll just discuss in brief about what basically is BiPAP. So basically, whenever we are giving a positive airway pressure during inspiration, what is we call, that is known as a IPAP, and the positive pressure we are giving during expiration, that is known as a EPAP. Now, since you cannot keep all the patients on a ventilator, so you have this condition where you can also do a non-invasive ventilation. So what's the thing? So we have a IPAP and a EPAP. So This IPAP, which is something around 10 to 15 or even 20, and this is usually around 5 to 10. The important thing I want you to remember, this EPAP corresponds to PEEP. So you all know what does PEEP does in a ventilator. It causes recruitment of more alveoli, so you have a better gas exchange. And in CHF, it actually pushes out the water. So even in patients of pulmonary edema, what does the role of PEEP is? Even we talked about something in the patients of COPD, that it keeps those open, so it have a lesser pressure. So you have a auto PEEP thing over there. The important thing is this difference. So here this difference. So IPAP minus EPAP is basically the driving pressure. The driving pressure into the lung, and this determines the tidal volume. So how much of air you will be ventilating to the patient will be determined by IPAP minus EPAP, or many times you call it as delta. What is the difference? You call it as delta. This delta. So the important thing is the tidal volume is determined by the IPAP minus EPAP, and the EPAP basically determines the PEEP. So we can have certain conditions, and okay, this is centimeter of water. This pressure is in centimeter of water. So let's talk. So we have, this is IPAP oblique EPAP, and this is a delta. So you can have, let's say, 10 oblique 5, you can have 50 oblique 5, you can have 50 oblique 10. In a delta, this is 5, this is IPAP minus EPAP will be a delta is 5. Here we will have 10, and again we will have 5. So of course here the tidal volume will be maximum. Okay, so the TB will be maximum here. But what about this? Are these same? In this 5, yes, the tidal volume is same, but here look at the EPAP. So here you have a high PEEP. So in a condition, let's say when you are talking of a condition of CHF or pulmonary edema, where you actually do not require lot, and the problem is not of oxygenation, because you know EPAP, the tidal volume is for CO2, and this will be the PEEP will be for oxygen. So and the problem, the oxygen is almost good. So here in this kind of condition, you might actually prefer this setting over this setting. Even though you are ventilating same, the effects you are getting is similar. And we can always use an IPAP EPAP for the same situation. So you can also have this, of course these settings are very basic one. Of course you can always have, you have multiple settings here. So if you keep IPAP and EPAP same, if you keep both IPAP and EPAP same, then this becomes your CPAP. So when IPAP and EPAP becomes same, then this becomes your CPAP. So that is a continuous positive airway pressure, irrespective of whether you are inspiring or expiring, you are getting a same positive pressure. So basically a BiPAP machine can work as a CPAP, but in a BiPAP you always get an option of IPAP and EPAP, which you don't get in a normal CPAP machine. This is a basic difference. So we discussed about the IPAP, EPAP and FiO2, and then the role of these settings. So IPAP minus EPAP, which is a delta, that determines the driving pressure, basically determines the tidal volume for the patient, and EPAP is just like the PEEP in a ventilator. So again, in a patients who are having the pulmonary edema or CHF, you prefer a high EPAP as well as a high IPAP. So you get almost a common amount of ventilation, and you get the positive effect of the PEEP. So that's it, and in the next part we'll be talking, the last part of this mechanical ventilation series, we'll be talking about the how do you wean the patient off from the ventilator. So thank you and namaste. and please be safe.